A good amount of my focus is going to be particular to an EMR, but there will be stuff that will translate to paper also. In talking to most of my colleagues that use a scribe, there seems to be a pretty big dichotomy right now between who the scribe is in each practice. And it runs the gamut from the newest, least experienced person to the most experienced person who knows how to do lots of other things. And it seems to be those two extremes, and barely anybody in the middle. There's reasons for both ends. The actual scribe job of putting what the doctor tells you down on paper in the EMR doesn't necessarily require years and years of experience, but a lot of people use their most experienced people so that they can also, besides getting the information in the computer, but after the doctor leaves the room, answer questions, get forms filled out, and play more of a right-hand person than someone who's newer and less experienced. So I find when I talk to my other colleagues that there's a pretty big dichotomy. In our practice, most of the time it's the less experienced person that are doing the scribing, but we have it so that everybody knows how to do it and can jump in and do it whenever availability presents. So, for the majority of you that are using an EMR, the one thing, if you get one thing out of this, you need to know that EMR inside and out as a scribe. Every system you're going to work on is different. Some of the EMRs are mostly on a single page. A lot of them you have to click in and out of a lot of tabs to get stuff in. But you need to know yours. And you need to know it really well. When the main thing the physician wants out of their scribe is to be able to get the information that they're seeing at the slit lamp into the record while they're doing the slit lamp exam. So in most situations, what's going to happen is the doctor's going to spout off a bunch of findings, and you need to get them down on paper or in the EMR. And if you don't know where they go, you're going to struggle. You do not have time to try to figure out on the fly, where does this go? All right? Now, at the beginning, when you're first learning, obviously everybody's not going to know exactly where everything is, but in order to get good at the job, you need to know this. So if you're starting off doing this, one of the jumping off points is learn the anatomy, okay? You need to know what is a cornea, what's conjunctiva, where are things, and generally, most of us, when we're doing a slit lamp exam, we are going to move from the front of the eye to the back. And so the only way you're going to know what section should I be in here is to know the anatomy as we go backwards. Okay? So most EMRs are set up to flow that way. The external exam is towards the top, the lids are next, the slit lamp exam comes next, and it goes conj, cornea, anterior chamber, iris, lens. And so the EMR is set up that way because that's the way we're taught to think. when we do a slit lamp exam. Start at the front and move backwards. So what you're going to hear as you're scribing is going to go, for most people, in that order. The vocabulary. Okay? We speak a totally different language. Certainly than lay people, but even than other physicians. If you have two ophthalmologists talking to each other and three other doctors around, they don't understand a word we are saying. Okay? Our abbreviations are different from the rest of medicine. Our vocabulary is different from the rest of medicine. You gotta learn ophthalmologies, right? And that's, again, the only way you're gonna do your job well is to learn the vocabulary. The anatomy, the vocabulary, and your EMR entry data. So how do you do that besides doing it on the fly? The best thing is, if there's downtime, and I'm sure there are days there aren't any, but there are days that there are, or times that there are, play around in the EMR. Get a test patient, enter Jane Doe, and go in and out of every tab, and start to recognize where things are. Most EMRs are organized by either anatomy or pathology, but there's some degree of organization. Some systems are better than others at doing that. Some are more intuitive than others. But you got to deal with what you got. So you may have a great system, you may have a crappy system, you got to make it work. And the best way to make it work is for you to constantly, when you have time, play around with every tab. Okay? There's a tab for conjunctiva, open it up, see what all the stuff that's in there, how does it rate things, does it 1 to 4, does it do mild, moderate, severe, how does it do things, right? You gotta learn how to get this stuff down and where it goes. You don't have time to search. When I rattle off 7 different findings, you can't be thinking about, where does that go again? You gotta know it. Now this is a suggestion. We started doing this in our practice, I don't know, probably 4 or 5 years ago. We were a pretty early adapter to EMR. We've been on an EMR for 9 years already. One of the things that I have found incredibly helpful is my scribe reads to me the abnormal findings from the last exam while I'm doing that part of the exam. Most EMRs, or if you're on paper, you can look back to the exam before, and most EMRs bring last time's findings forward so that you can, in your today's visit, see what was abnormal last time. Now, from our side of what we do, I don't want you to read me everything. I just want you to read me the abnormals in the pertinent section that I'm examining, because it makes it way faster. On a retina exam, if I know that on last exam there was a choroidal nevus in the inferior temporal quadrant, it's a heck of a lot easier for me to go right there and look at it and determine, is it the same size, is it the same thickness as it was before, than if I'm just scanning around and I don't know it was there. And look, I look at the last exam before I go to check the patient, but by the time I'm in the middle of my slit lamp exam, I don't remember what was there the last time. But if you read it out to me while I'm doing it, I can just say, that's the same, or no, it's not. Take that out, okay? It makes it way more efficient. So, does anybody do that now? Only 1 or 2 people. I think what you should do is talk to your physician and see if they want to trial this, because it has been a tremendous help. One of the biggest reasons I like a scribe in my room is because by the time I get through the slit lamp and go to put it on the page, I can't remember half the things I saw. So, especially if you're trying to do, you know, a lot of our patients I will see after they're dilated. So when I go into the slit lamp, I'm trying to remember, you know, do they have gutata? How much nuclear sclerotic cortical cataracts? Do they have, you know, a pterygium? What's their cup to disc ratio? And then I'm trying to do it on the other eye. And by the time I go to turn and put things down, I just can't remember all that stuff. So the whole point of having a scribe is so I don't have to remember all that stuff. I can see what I'm doing. I can tell you, you can put it down and we're moving on. But if you read out the last pertinent findings, it makes that so much easier because I can just say as we go, yes, that's the same. So when I go pick up my little 78 diopter lens, the scribe knows I'm going to do the vitreous and retina exam, and they're going to start reading me off. The cup to disc last time was 0.35, stable. The retina was fine, stable. There was PVD, yes. I don't have to remember anything, and everything gets redone very quickly that way. So I'd encourage you to speak with your physicians and see if they would be interested in having you do that. If you don't do it, and trial it for a little while. I think they will be very happy once they start hearing that, and makes it way more easier for them to get through the exam. The other thing that I have the text read as I do is the last IOP. Especially in a glaucoma patient, they are totally focused on what that number is the majority of the time, okay? So before I had people doing this for me, the typical scenario would be I'd have a scribe, I'd get to the slit lamp, I'd check the pressure in one eye, and I'd say, pressure in the right eye is 21. The patient goes, is that better or worse than last time? I'm like, I don't know, let me look. But now they read it out to me before I check it this time. They'll say, pressure last time was 18. So as soon as I say 21, I know I'm going to be in for an onslaught, but I'm prepared for it. It is tremendously helpful for those overly anxious, you know, OCD patients that want an answer to how does it differ from last time the instant you read the number off. Now, before I had a scribe, it wasn't an issue because I never said the number out loud, so they didn't jump all over me. But now that I'm reading it off to a scribe, if I don't know what that last one is, there's going to be instant panic. Okay? So it's very helpful. And the patient learns, you know, after we've been doing this for so many years, the patient learns that. The scribe's going to read off last time, and you're going to tell me the new one. And so it just makes it way easier for everybody. The patient, me, if they get that instant gratification of knowing what the difference was between last time and this time. If you work for multiple doctors, you should probably have a little conversation, if you're going to do this, reading out of stuff in advance, exactly what they want to hear. Because it's going to vary from one person to the next. And some people may not want to hear this at all, and some people may want to hear a lot of stuff. And sometimes it differs depending on the exam. Now, if we're doing my post-op day 1 cataract surgery patient, don't read to me what the lids had last night. I don't care today. Today, all I care about is the cataract surgery stuff. I only care about the eye that I operate on. So, you know, if I operate it, normally we do everything right eye first, then left eye. You know, if I have somebody in who's on, you know, 1 week post-op of their left eye cataract, don't read me the right eye stuff. I'm not looking at the right eye today, I'm just looking at the left eye. So there may be variations from doctor to doctor, from exam to exam. Try to figure it out with them what works best, because it does make things go way smoother. The other thing that's going to vary a lot from physician to physician, for the most part, everybody's going to want you to record the exam. The bigger issue is what happens with the assessment and the plan. Okay? And that also is going to vary a lot by what system you're using, because some systems automatically drop things to the assessment when you click on a finding. Like in our system, if I click on 2+ NSC in the cataracts, in the slit lamp exam, nuclear sclerotic cataract automatically pops up as an assessment. I don't have to do it, I don't have to enter it, it just happens automatically. Not every system does that. So you also need to decide, are you going to populate some of the assessment and plan part, or is the physician going to do that? Okay. For our practice, for the most part, I enter the plan. The EMR does the assessment for me because it brings it down from the exam part, but I enter the plan. Some people, some physicians may want you to do that as they talk to the patient. And so as they're explaining to the patient what they have, they may want you typing that discussion in to the plan section. So you have to figure that out. That's not a universal, everybody does it the same way. Now this is where we get more advanced, is trying to anticipate what comes next. Okay. This is where a lot of my colleagues decide to use their best, most experienced person because they do this better. Okay. If I'm sitting there, and again, it depends on how your office runs and who does what. But if I'm sitting there starting to have a conversation with the patient about their glaucoma that's not in control, and I think the next best thing is for us to do an SLT, depending on how the rest of the office works, it might be the best thing for the scribe to run out of the room and get the SLT consent form and bring it in while I'm finishing the discussion. If I'm sitting there talking to the patient about their dry eyes and we're discussing the possibility of putting in punctal plugs, and you don't have punctal plugs in every single exam room, it might be a wise idea to get up and run and get the punctal plugs. Try to anticipate what's going to happen next. That's where your value jumps up quite a bit over, I'm just typing things into a computer. Do most people use electronic prescribing? Yes? Anybody not use electronic prescribing? Okay. So, if you're talking about prescriptions, if there's things that need to be written, so even those of us that do the overwhelming majority of electronic prescribing, there are some things we still need to write scripts for. You want to get a CAT scan, you want to get a carotid ultrasound. Those things still, I mean, unless you're linked to a lab, which most of us are not, because we don't do enough of it, we just do drug electronic prescribing, then you got to make sure that prescription pad is ready, right? And maybe you start filling the patient's name at the top. So, you know, if you start having a conversation with, I want to order a carotid ultrasound for you, whip out the pad, start writing the patient's name, get things moving, right? Same thing with forms. If we're having a discussion, you know, it depends. For us, for surgical stuff, if I decide somebody's going to have surgery, their next move is I'm going to take them out to my surgical coordinator. So in my office, this stuff isn't something that the scribe's going to do. We're going to move them to another patient. But that's not always the case. So does a consent form need to be done? Do you do a cataract surgery lifestyle questionnaire? Sometimes people who do a lot of multifocal lenses, they want a questionnaire over, do you drive a lot at night? Do you read up close? Do you do intermediate? So if there's a lifestyle questionnaire, get it out and get it ready if there's a conversation going on about cataract surgery. Drops, you know, post-operative drops. If you have a typical regimen, is there a drop instruction sheet that you could fill out, before the physician even gets in? In our practice, that's what happens. The scribe knows what I normally do, and they write the post-op drop instruction sheet for the patient out before I come in the room. Do I change it every once in a while? Yeah. It's every once in a while. The majority of the time, whatever they wrote out is what we're going to do. If you tend to give literature to a patient, whether it's multifocal lenses, or if you have information sheets on particular conditions, like we have a blepharitis sheet, tells you how to do warm compresses, tells you how to clean your lids off with baby shampoo. We have one for flashes and floaters, what to look for. So if the practice has literature that is pertinent to the patient's problem that's being discussed, get it ready. However your practice does that. Some people have the sheets in every exam room, some people print them up as you go along, but however it's done in your office, get it going. Listen to the discussion that's going on between the physician and the patient and try to figure out what is he going to want to give this person at the end. If we're having a big discussion about flashes and floaters, that flashes and floaters sheet should be sitting on the desk ready to give to the patient, right? You got to listen to what's going on and process it. Just standing there and repeating things is not going to be your best avenue to stay really out there. Next appointment, again, most people are going to just send the patient up to the front desk and they're going to do it, but there are some times in our practice where the scribe gives the person the next appointment in the room. So you should know how to do that. Okay? That's a different function that most scribes aren't doing all the time, but you should have some idea of how to work the front desk part of things to give the patient an appointment if necessary. You need to know where everything is. Okay? Just like you need to know where everything is in the EMR, the physical stuff in the office. Even the most EMR-centric practices still use paper for some things. You need to know where to get all those papers, whether it's literature or consent forms or an IOL selection sheet. Where are they? How do I get them quickly when they're not where we need them? Rarely used items. So again, I'm going to speak just for our practice. I'm sure there's a lot that are similar, but we have certain instruments and stuff that we don't use that often, so they're not in every single exam room. Okay? So in our main office, I have 5 exam rooms. The overwhelming majority of the things on this list are not in every exam room. I don't have a tetanus test in every exam room. I don't have a Maddox rod in every exam room. I don't have a set of prisms in every exam room. If you don't have one in every room, you gotta know where to go to get that. You can't be searching around all the time. With the burr for corneal foreign bodies, not in every room. So where is it? And the guy who comes in who's got, was working on my brakes yesterday and something fell and now it hurts, that burr should be in the room before I get in there, if it's not in those rooms already. So you got to start thinking about all the little things that get used but don't get used all the time and not in every room, and do you know where they are? And can you get them quickly? Sample medications and coupons, you should know where all those are and how to get them quickly. And again, listen to the discussion. If I'm talking to somebody about putting them on Restasis, and we've got the little booklets from Restasis that gets them a free month and go get it if it's not in the room already. Listen to the discussion and react to it. Simple maintenance items. If you're still using projector charts, you should know where the bulb is, because they burn out a lot. All right, the handheld instruments, you should know where the bulbs are. You should know where the slit lamp bulbs are. Something that's going to go down on us in the middle of an exam, you need to know, where do I go get that to fix this? All right? There's nothing worse than having to stop and the physician to walk out of the room in the middle of an exam because we can't find the slit lamp bulb. Right? You got to know where that kind of stuff is. Same thing with the supplies we use all the time. You know, sooner or later, the room's going to run out of tissues. It's going to run out of alcohol swabs. Well, where are they? So you can get them quickly. And the cleaning products. The spray cleaners. If you have a separate cleaning protocol for people with acute conjunctivitis, do you clean the room differently when you get someone in there that's got a known contagious disease than what you do between each normal patient? If there's a protocol like that, you got to know, you know, is there special cleaning stuff for that? What do I need to do? Where is it all? So most scribes in most practices, besides doing scribing, also run most of the equipment. So you got to know how to use a lens meter, autorefractor, topographer, visual field, photos, OCT, or any other machine your practice has, okay? That is something that you should be able to, because if you're in there and a scribe and I'm halfway through the exam and I decide, okay, this person's got a new field cut, I need a visual field test, you got to be able to take that patient out and put them on the field machine. So you should know how to run all of the machines in the practice. You can get certified as a medical scribe. There are two organizations that do it, the American College of Medical Scribe Specialists and the American Healthcare Documentation Professional Group. The main reason this had come up a lot is CMS had put out a feeler to require all scribes that entered things into an EMR to be certified. Okay, that got roundly criticized, and at least for now does not exist. So they put that out as a potential rule. It got hammered. They pulled it back. It doesn't mean it won't happen again later. But right now, there's no CMS requirement that you be certified as a scribe. But just be aware that that had been floated in the last 2 years, just didn't get put into existence. So that's all I got. So, like I said, the best thing you can do, learn your system, learn where everything is, learn the vocabulary of the anatomy. That's what makes you function well, and the more extra stuff you can do, the better. So it's a process that you should continually be learning how to be better at doing this. There's never a point where you got it all, okay? There's always more you can learn and always more you can do, and you should be striving to do that. Any questions? Okay, thanks. Sure.